Alrighty, whenever you're ready.
I've got to say, I'm a fan already.
I know, I thought the same thing.
All right. Well, obviously, I am a firm believer that primary care has to be an area where respiratory therapists are involved much more so than we have been in the past. And I think the opportunity is arriving. We've had a lot of barriers to this due to reimbursement and a lot of other issues, but I think the times are changing. And hopefully this will give you a little bit more understanding of why I think that way. So let's get going. All right, I like to throw this one out there. I couldn't remember if I kept this on there or not because it was getting a little bit big, but to prove my my bona fides and why I actually do a lot of the Star Trek things. I've been a Star Trek fan my whole life, even converted or assimilated, you might say, my daughter into getting that, and actually had the pleasure of meeting Mr. Shatner a few years back at a Star Trek convention, which was really cool. Unfortunately, maybe ironically, I never did get a chance to meet Leonard Nimoy, but obviously that's been a big part of why I use Star Trek to go forward with a lot of COPD things and that sort of stuff. So as you see, the longer version of this has a lot more Trek stuff in it, but this is always a good intro. So next slide, please. So what we're going to learn today is we're going to check out how we can, as RTs, affect this strange new world of disease management, figure out where these gaps are. We're going to seek out new patients. Obviously, we see a lot of patients in the inpatient world, but we need to be seeing these patients out in the clinic and out in the community. And finally, we will boldly go where very few RTs have gone before. I talked to a couple of people around the clinic here. It's always very exciting when one of us, excuse me, in the outpatient world finds another one, because it's like, oh, I'm not alone. There are some other people out here in the wilderness. I met a couple of RTs from out at Intermountain in Utah at AARC Congress last year, and that was really a neat experience. We're able to kind of share. We discovered some of the same barriers, some of the same things that smooth the way, and it's really nice to share that experience. So, but we need more of them. And COPD is going to be one of our biggest entrees into this area, I think, because so far we know that COPD is a problem. It has, for the last few years, it was the third leading cause of death, and then they refigured all of the trauma numbers and the opioids and everything, and they bumped it down to fourth. But that doesn't mean we're making any progress. And we've been looking at these things like readmission reduction programs, patient navigators, discharge or transition plannings, meds to beds, rapid follow-up with the primary care provider. They all have kind of this one thing in common. They all start in the inpatient world. We wait until people get admitted with an exacerbation. They've already lost a huge amount of lung function, and then we start trying to get them better. But what if we start changing that paradigm a little bit? What if we start going at it a little bit earlier? Next slide, please. That's what the UK guidelines tell us. The responsibility for diagnosing, treating, reviewing these individuals rests with primary care. This is particularly asthma world, but we can see that this is also relevant in COPD, because on the next slide, we hear from Dr. Byron Tomashow, who is the chair of the board of directors from the COPD Foundation, back from when they launched the National COPD Action Plan, I think 2 years ago now, at the ATS conference. So next up, please. I think we might have to hit it one more time.
Oh, sorry.
All right, so the audio doesn't come through great, but what he's saying is this disease has to live in primary care. We're not finding a lot of the people. We know we're missing about half the people with COPD because we're not diagnosing them properly. We know that we're missing huge opportunities to impact their care earlier in the process. And this is a pulmonologist talking. This isn't just, this isn't an RT, this isn't a doctor. This isn't, he's a primary care doctor. He's a policymaker, and he's a pulmonologist. And he's saying pulmonologists can't carry this load. It has to be in primary care. But there are some problems with that too. Excuse me. We see that this study came out, it's getting a little bit long in the tooth, but a lot of the data is very similar. If you look at some of the newer things that are coming out from NIH, the doc style surveys, we see here that only about half of the primary care providers, whether it's MDs and DOs or whether it's the dreaded mid-level provider, my wife is an NP and hates that phrase, the advanced practice non-physician provider, We see that a large section of these populations are not using, and in some cases are not even aware of best practice guidelines for COPD management. Not necessarily using spirometry, not using the box, not even necessarily using ATS or ERS standards. And of course, on top of that, we have very limited access to pulmonary rehab, which is another major issue. Next slide, please. Again, the biggest issue of why these things aren't happening isn't because people don't care about COPD or they want to be a bad provider or they're just blowing people off. But we go back, again, a study, this is another one of those things that isn't looked at very often. But this group led by Ming-Tai Seal found that about 10, I think this came out in 2007, so a little over a decade ago, they found that the median primary care visit was 15.7 minutes and covered about 6 topics, which means at best, advance a little bit, please. There it is. 5 minutes a topic at best. So you're talking 5 minutes for inhaler technique, care management, screening for sleep disorders, spirometry, making sure that they're on the right meds, making sure they understand the regimen, making sure that they're connected with pulmonary rehab or at least getting some exercise, tobacco cessation. All of these things we're trying to jam in 5 minutes and then move on to every other topic, diabetes care, arthritis care, gout, CHF, the list goes on. We're trying to do all this stuff in 5 minutes and it's just not working. Next slide, please. So in order to figure out how we can do that, we need to take a little bit, and again, this is more of a broad view when I talk to a lot of frontline RTs. We look at this idea of the hospital readmission reduction program, which many people are probably familiar with, came out of the Affordable Care Act, and perhaps more importantly, the Medicaid Access and CHIP, or Children's Health Insurance Program Reauthorization Act of 2015, or MACRA. This was called the permanent doc fix because instead of having to pass a law through Congress to adjust Medicare reimbursement every year, excuse me, one of those days. I need a respiratory therapist in my clinic here. Anyway, in addition to doing that permanent doc fix, what this also did was introduce this concept of value-based reimbursement to the conversation, where instead of maybe getting paid for the quantity of what we do and all the procedures and all those CPT codes, we're getting paid for the quality of what we do and how we actually impact people's lives. Came up with these ideas of the quality payment program and some other alternative payment models, which we'll talk about in a little bit more detail as we go on. But this is really where the conversation starts. Next up, please. So again, everybody's probably pretty familiar with the hospital readmission reduction program. If your facility underperforms a COPD population, you're going to get a penalty of your total Medicare reimbursement, not just the COPD folks, but your entire Medicare check, up to 3%, depending on how they calculate how many excess readmissions you have. It's not a overall number of readmissions. They try to take into account some of the social determinants of care and all those sort of things, compare relatively apples to apples as best they can. But if you're not doing what you're supposed to do for the COPD population, you're going to get penalized. But again, the biggest weakness of this program is you're already starting kind of behind the 8 ball. You've got people who are already sick, people who are naive to any kind of treatment in many cases, don't understand the processes involved, don't understand the medications, don't understand their care, can't be self-effective. And so then we're trying to jam all of this stuff into the transition plan and then dump it on the primary care provider in their little 5 minutes. Again, just doesn't really work. Next slide, please.
Mike, can I interrupt you for a moment? Can we
Absolutely.
middle of this, or would you prefer we hold it till the end?
What's that?
Can we ask questions in the middle, or would you prefer we wait till the end?
Oh, hey, this is your show. I'm happy to answer any questions at any time.
Okay, great. Dr. Doyle, did you want to ask?
Yes, Mike, on this slide that you have up right now, is this a threat or is this really actually happening?
This is really actually happening. This program was phased in, I believe, in fiscal year 2015, where they started with 1% and then went to 2% and then went to 3%. It started as a pilot with a couple of other conditions, pneumonia, I believe a total hip arthroplasty, a couple other odds and ends. Then it seemed to work for improving these care processes, and so they added things like CHF and COPD. But at this point in the process, this is actually happening. There are hospitals getting penalized for excess readmissions.
And how about your big tertiary care hospitals in Grand Rapids?
Well, I can't speak a whole lot to them, but we do talk a little bit about, because I'm actually from Kalamazoo. But
I'm sorry, how about your hospitals in Kalamazoo?
Well, spoiler alert, some of that data is coming up in a little bit.
Okay, great.
All right, so again, we're going back to MACRA a little bit. We've seen that these readmission reduction programs are kind of a good idea in theory because they're trying to move the conversation to what should we be doing. But then we look at this MACRA, and instead of shoveling through all these patients and keeping our median visits at that 15 to 16 minutes, instead of looking at what can we get paid for and trying to cram all that stuff onto people, next up, please. We should look at what we should get paid for. What are things that are actually improving people's health? Next slide. Or next, and then that tells us how much money can we save, because we also know that when we're doing appropriate, efficient care, and there are some other slides that I took out because I wasn't sure how applicable they would be to this, but we know that when respiratory therapists provide care in the hospital with therapist-driven protocols for anything from bronchodilators to ventilator management, we know that resource utilization goes down, in some cases by 40 to 50% even. So we start looking at this whole idea of not only are we saving money, not only are we getting paid for what we should be doing, we're able to spend more time, have an actual patient-centered conversation. All of those things that we know in theory and we sing the praises of, we can actually start executing that. And so how do we pull that off? Well, this is one of my favorite stories because I realize how very fortunate I am in my role, but this is also an example of those cliches become cliches for a reason. You hear all the time things like you miss 100% of the shots you don't take and all that stuff. That really does happen. And it happened to me. This was an actual email I sent in November of 2015 when I was wrapping up my bachelor's degree. I was at a very small facility in the lower Michigan area. I'll say that not a lot of opportunity for advancement. I really wanted to do something else with my bachelor's degree. I had learned a little bit at that point about how poorly we were doing our COPD education as a healthcare system. I had by this point started a Facebook group called COPD Navigator that is basically intended as a support and educational group that I'm not trying to sell anything, not sponsored or anything like that, just trying to give people the tools and the information they need to be their own best advocate and to participate in their care. And I thought, well, how can we apply that in the real world? So in Kalamazoo here, we have a fairly new medical school, one of the newest in the country, and at this point, it was still kind of in the startup process. And so I tracked down the dean's email. I figured, well, we might as well take it, go big or go home, right? So I basically cold emailed the dean and said, hi, I'm a random respiratory therapist from the community. I live in Kalamazoo, great to see medical school. I think this is how we can participate. I think this is how we can do a great thing in public health and community health and all of these things. Hope to hear from you soon. My expectation was that I would never hear anything from him because after all, he's the dean. He's got a lot of stuff on his plate. At best, being right before the holidays, I thought, oh, it's great to hear from you. I appreciate reaching out from the community. You'll never hear from me again. Thanks a lot. Next slide, please. About 20 minutes later, I got an email reply right from the dean that says, I'm copying our associate dean for clinical affairs and our chair of medicine in this reply. This is a good idea. Much of how we can execute this depends on what our those big hospitals are doing, Bronson Healthcare or Bronson Methodist Hospital and what is now Ascension Borges Hospital. We're off and running. So next slide, please. So that December, after we locked some of that stuff down, had a good meeting with the associate dean and the chair of medicine. We started moving forward with, next please, started moving with how we can, what are we going to do in the clinic? What screening tools are we going to use? How are we going to evaluate our patients? What standards are we going to use for severity staging and tracking? There's a lot of different paradigms out there these days. Next slide, please. In March, I was able to attend the NIH COPD Town Hall, which begat the National Action Plan, which was a great event in Bethesda. I had not officially been hired on at WMed, but they basically said, yeah, go there. We're going to participate in this, and we're going to move forward. So it was a great opportunity to, again, it was a win-win. We were able to participate in that, and as a new medical school, get some more of our branding out there. Next up. By the time July rolled around, it did take a little bit of time to get all the, cross all the T's and dot all the I's, but I was able to write my own job description, which not many people get the chance to do, officially posted, and then applied for the job, of course. And then on August 1st, which I think is our next one here, started orientation. And then October 6th, 2016, I saw my first patient. So we're looking at 11 months from proposal to execution. Now, I recognize that this is not always the way it has to go. Not everybody's going to have a fortunate opportunity like this, but this definitely proves that something like this is possible from a cold start. There was no framework in place. There was nothing even on the horizon. And in 11 months, we were able to get this off the ground and integrate into a primary care clinic. As to the question of how we were able to do this, I'll go ahead and advance, please. In Michigan, this is at the time that we started the clinic, we had about 80 hospitals who were involved in the readmission reduction program. Slightly over half of them were listed with excess readmissions. The way they figure it is there are a lot of variables. We can have 18 slides just in the formula that they use to assemble this thing, but you're basically looking at looking for a ratio of 1, which is the expected ratio to what you're actually doing. Our ratios were on either side of that. We had some hospitals that were doing very well, some that were not doing so well. And if we look at the next slide, we actually get to answer that question. In Kalamazoo, at the time this launched, we were actually doing pretty well. We were below that expected readmission thing. And so even though our community had been taking COPD relatively seriously, again, potentially another barrier, we were still able to get this off the ground because we still weren't quite taking it seriously enough. This is very applicable in West Virginia. If we go to the next slide, I believe we look at, this is some data that I looked up because I looked at, this was West Virginia University, so I figured this was pretty applicable. Similar ideas, we got about half the hospitals available. We had a similar range of ratios. So again, it's a very similar environment to what we saw in Michigan, which again tells me that this is very a great opportunity in that neck of the woods as well. So next slide. What do we actually do for these folks? First off, everybody gets spirometry. Everybody who comes in, this is still recognized as the literal and figurative gold standard for diagnostics. We make sure that everybody gets spirometry. Nobody is diagnosed simply on history of smoking or anything like that. We make sure people get alpha-1 screening, whether it's in our lab or we use one of the kits that are available, because again, this is one of those areas where we're horribly, horribly under-diagnosing and under-recognizing and therefore under-supporting this group. So we try to tag those folks. Next up, we do the COPD assessment test score. This is the one we landed on. It's kind of, in my view, split right down the middle. It's not as complex, not as time consuming as the St. George's or even the St. George's COPD questionnaire. A little bit more detailed than the MMRC, a little bit more, for better or for worse, we get a look at some of the other domains like sleep and energy level. Again, we have some confounding factors there sometimes, but this gives us a little bit more holistic view of the patient as a whole, instead of just looking at their spirometry numbers. Next up, we do a medication review. This is probably the biggest bulk of what I do. I make sure that people are on the right meds, they're on the right regimen, and they know how to use their devices. There are a lot of folks out there who get a rescue inhaler and they figure, well, that's their thing. Or I have a lot of people who have the dreaded the Spiriva Advair combo where you have 2 puffs once a day and 1 puff twice a day. And we work and we work and we work to make sure that people have the reminders, the understanding, and everything they need to be taking their meds on their right schedule. We also look at, can they use the devices? In my view, and I will say, I will disclaim that Boehringer Ingelheim did give me, sent me out to do a presentation at Congress last year, at the International Respiratory Congress. But even before that, I've been using these devices called the in-check dial and the aerosol inhalation monitor because peak inspiratory flow and inhaler timing are, again, sorely under-evaluated. We don't always know if the patient is getting their medication. So they come back in 1 month, 3 months, whatever it is, and they say, hey, doc, that inhaler you gave me didn't work. We don't know if that's the medication. We don't know if it's not on the right schedule. We don't know if it's the technique. Those are all things that are going to impact care, impact readmissions, impact index admissions, all that stuff. And also make sure everybody has either a full-size valve holding chamber, or in a lot of cases, particularly with rescue inhalers, I give them a small device called an inflow cone, which is basically just a miniature spacer, helps with coordination, all that stuff. But again, we're trying to make sure they have the knowledge and the tools they need to be effective in their own care. Next up, please. Also do, of course, a ton of tobacco cessation. We all know we've got a lot of folks in the COPD community who are still smoking. We do the pharmacological stuff, but we also focus a lot on counseling, the habits, the rituals, all that sort of thing. I open up that I was never a smoker myself, but I was a snacker. I've struggled with weight all my life, and a lot of the same psychological and even biochemical reactions. We talk about the reward centers in the brain. We talk about endorphins and all those kind of things. We look to develop new habits. We don't look at it as necessarily a single event of a quit, but we look at building new habits so that they have a new security blanket that isn't going to poison them all the time. Next up. Also make sure we do all of our referrals. We send people to pulmonary rehabilitation when we can. We have a pretty long waiting list at our 2 programs now. Make sure people are evaluated to see if they need a sleep study. We work with our DME providers to make sure they're on the oxygen and the nebulizers and every other piece of equipment that they need. Again, we're just trying to make sure that to take some of the load off the physician in these cases, but the provider, and make sure that everybody is being taken care of as much as possible. Next up, please. Make sure that they have an action plan so that they understand their symptoms. They understand when to call us, when to call the ER, when to call, when to just take it easy for a day. We give them a reference packet with some paper instructions and also links to YouTube videos and stuff for things like pursed lip breathing and huff coughing, some resources from the COPD Foundation, caregiver guides, all that sort of thing. Next up. The biggest thing we do is I try to coach them that we are all in this together. We had a football coach here at Western a couple of years ago named PJ Fleck, who had this philosophy of rowing the boat together, where we don't always know where we're going. There might be one person in the boat that sees the direction, but we all need to work together and coordinate with each other and talk to each other and make sure that our efforts are united. Otherwise, we're going to go around in a circle, or we're going to flip our little boat over. But if we do that communication, we do that talking, then we actually get from point A to point B. So this is, again, a huge part of my time. How do we execute this in a clinic? A couple of different alternatives. There's the merit-based incentive program, various other alternative payment models that are always kind of being tweaked by Medicare. There's a new round, I think, being evaluated right now. Again, these are basically things that are driven to increase quality and not necessarily quantity. Go ahead and take a look at the next slide. What we're looking at here also, a lot of times when we're starting to look at quality benchmarks, we're looking at outcomes. These are not necessarily outcomes. These are you adhering to the best practice guidelines? For example, in COPD, 2 of them are the use of spirometry and the use of a long-acting bronchodilator. The practices have to pick 6 of these categories, and here we see 2 right away that are covered immediately by a respiratory therapist. So automatically we're giving offices the tools they need to hit these guidelines just to make sure that they're being used, not that they're keeping people out of the hospital, not that they're reducing exacerbations or anything like that, just that we're doing what we're supposed to do and letting things play out as best as we possibly can. Again, we're looking at this whole quality-based thing instead of just outcomes and numbers and all that stuff. Next up, please. This is still being integrated. Right now we see that the adjustments in this merit-based incentive system, if you're hitting all of these quality marks and you're doing all of these things, you can actually get up to right now a 4% bonus in your Medicare reimbursement if you participate in these programs. By the time we're looking 3-4 years down the road, we're looking at 9%. Conversely, if you're not doing these things and you're not providing efficient care, you're going to get a ding. You're much like the readmission reduction program, you're going to lose out on some of that money. So at best, you're going to hit the baseline, and you're not going to get what you're still not going to get what you could do. And if you're really poorly performing, then you're going to drop underneath and you're going to get penalized. Again, this is one of those things that is in place for these practices that are participating in these. Not a threat or anything like that, but they're hoping to use it as more of a carrot because they're trying to push people into that higher end of the adjustment. Next up, please. So again, what it comes down to, again, we'll throw it back to Star Trek. They're the Ferengi are kind of the ultimate capitalists, and they have these rules of how to be ultimate capitalists. But one that's applicable here is the riskier the road, the greater the profit. So that's what a lot of these alternative payment models are looking at. They want providers to be a little bit more creative. They want people to look at taking some risks on hiring an RT or doing other things out there. And in response to that, if they're willing to take these risks, then Medicare will provide them, or CMS will provide them extra reward down the line. Again, we're looking for more for carrots than anything else. Next up, please. There we go. So some of these alternative payment models, many people have probably heard of accountable care organizations. There's this plan called Comprehensive Primary Care Plus. That's a lot. We're using that a lot in our area. There's shared savings programs, demonstration programs. I would refer you back to Medicare to find out what their flavor of the day is, because it does seem to change fairly regularly. But again, these are all different avenues that practices can take advantage of to get some of these new services out there. Next up, please. Even under the existing model, we have this concept of incident to billing, where a lot of this stuff I do, not so much maybe the counseling and the education, but things like spirometry, pulse oximetry, home oxygen evaluations, tobacco cessation, all of those things the provider can get billed or can get reimbursed for as long as they're physically in the building through this whole guideline of what they call incident to billing. And this comes right from the American Association for Respiratory Care billing guidelines. Doesn't mean that they have to be present in the room. I don't have to tie up a physician to do this stuff, because what would be the point then? But if they're in the suite, if they're in the building, and they're accessible, like, if I'm giving somebody tobacco cessation and they have a heart attack because of it, I guess, I don't know, then we can still bill like they're here with us. So again, we can truly be a physician extender. Next up, please. And again, there are lots of other ways to go about this. Carolinas, what is now Atrium Health in North Carolina, South Carolina, I think they just went into Georgia, got a grant from their state Medicaid program to put RT case managers in a lot of their rural primary care clinics. Had fantastic success with their, I think they knocked their readmission rates down something like 80%, just because they had experts providing care coordination and patient education, making sure people were, I know, a broken record, but connected with the tools and resources they needed to be self-effective. Next up, there are also direct third-party billing. There are some groups in Texas that act as sort of consultants. They will contract with some of the big providers and say, we will take care of your COPD population. You pay us a certain fee. We'll make sure that things are, we keep them out of the hospital. We do things efficiently. We don't wait until they're going to cost you a lot of money. Next up. Opportunity for creativity. Again, going back to some of those alternative payment models, the sky is the limit right now. This is sort of the Wild West still in a lot of these care models, and we have a great opportunity to take advantage of that as clinicians, specifically as respiratory therapists, as patient advocates. There's a lot of different ways we can go about this, so don't ever hesitate to do something crazy. Next up, please. So, of course, the meat and potatoes here doesn't work. It certainly seems to. Our first study, which was done about a year after we started, 76% of our patients that I had seen had clinically significant improvement, as defined as 2 points or more by American College of Chest Physicians, after 2 months. So their initial visit, their first follow-up, and their second follow-up, they had at least a clinically significant improvement in their CAT score. Next up. 80% of them had, after 3 months, they had clinically significant improvement. Next up, after 4 months, it's not necessarily that it's getting better, because as you might expect, the N goes down as time goes on. But the big takeaway here is this can be effective right off the bat, and we're at least seeing sustained improvements. These folks are not generally getting worse over time. Not only was it clinically significant, again, that cutoff is 2 points. In the responders, that 76% that responded, we saw an almost 6-point improvement just from teaching people to use their inhalers, making sure they're on the right meds, doing a couple of other tweaks here and there. And again, that was sustained over the 3 months too. And those folks that didn't respond were borderline enough so that they didn't really impact the, we still had the entire cohort improve too. So even, we didn't really make anybody worse. We at best maintained the status quo. Next up, please. In addition to being a fairly effective way to take care of our patients, we're increasing expectations of clinicians and patients to have access to respiratory care services, which from a professional advocacy standpoint is fantastic. One of the greatest reasons I wanted to do work in the medical school here is because I now have the chance to teach the residents to expect to have a respiratory therapist in their clinic, so that when they go out and join the real world in their practice, they're going to look around and say, hey, how come I'm teaching how to use these inhalers? Where's my respiratory therapist? How come we don't have a respiratory therapist? Let's go hire a respiratory therapist. Next up, this is a pilot implementation of something we kick around a lot, the advanced practice respiratory therapist model. I joke around a lot. My job would be even easier if I could just write for some albuterol from time to time instead of putting it through our EMR and jumping through all those hoops. I don't need, it could be a very limited license even. I don't need to be writing for opioids or morphine or antidepressants or anything like that. Just give me my inhalers and I'm happy. And we can demonstrate that this is a practical use of that time and that we can be responsible enough to have those duties in that scope of practice. Next up, one of the things that I'm very proud of is last year we were one of 6 organizations in the country, including the COPD Foundation, Atrium Health, Respiratory Health in Chicago, Breathe New Hampshire, missing somebody. 6 organizations had a subcontract through the National Institutes of Health for their Learn More, Breathe Better program to enhance community knowledge about COPD. We had a run of billboards for about 2 months, including November COPD Awareness Month. We've done several community outreach events. We've got some more on the horizon. We're specifically targeting through our program some of the underserved communities in Kalamazoo, those who have transportation barriers, health literacy barriers, all of those things, trying to improve our diagnosis and our education of those folks. When they can't always come to us, we're perfectly willing to go to them through some of these community programs. Again, not necessarily being an on-site clinician, but just making sure people know that they aren't alone and that there are people out there who can help them help themselves, basically. I think that's about it. Yep. And so, of course, we are not terribly proprietary or anything like that. So I'm happy to share all the information that we have. I have a couple of info sheets that I've done at conferences and such. I'm happy to share those, happy to share these slides, happy to share the full slide deck. Happy to sit and chat via email or phone or what have you. Happy to share our lessons, our experiences, and everything else with anybody who wants to do that, because the biggest thing is that we hope that this is the model that becomes fairly standard, because it seems to be helping patients, and really that's the bottom line. We're not in it to make money out of it or anything like that. We want people to breathe better. We want people to live their best lives, and the way to do that, again, is rowing the boat together in collaboration. So I very much appreciate everybody coming out this morning and listening to me ramble on for a while, and of course I'm happy to answer any questions right now.
Thank you so much. Guys, we do have about 5 minutes for questions. We do have a case to get to. Anybody?
Yes, this is Sam Giordano. A great presentation, Mike.
Thank you, sir.
I'm glad you mentioned MIPS. We were trying to generate some excitement and the utilization of respiratory therapists with that program. I think it's under-recognized in terms of its impact on how physician behavior and physician practices will be in the future, because it substitutes their payments. The biggest stumbling block we have faced for years has been incident to physician services. Many physicians, and this is a direct feedback, have indicated that they do not like to use respiratory therapists. They'd rather have them categorized as a Part B provider, because the spoiler, if you will, with incident to physician services is the respiratory therapist, if an employee of the practice, can only provide services in conjunction with a physician appointment, which means you have to coordinate the physician appointment, and then you just tag on, go see the respiratory therapist down the hall. You're right, they have to be in the premises. What we would like, and what frankly the physician community would like, is the ability to use RTs in Part B, but without direct billing, and that's not what we're after anyway, because it's difficult sometimes to coordinate the physician visit with the RT intervention. So in this way, the the patient could make appointments with the RT, who's an employee of the physician practice. We have proposed this over many years, many times with CMS. We've even had cost analysis done by reputable firms and showed that there's a possibility of a trade-off. But unfortunately, CBO doesn't do dynamic scoring. So if you're employed in a physician office as an RT, and even though the services that you rendered resulted in a decreased hospital admission, they will not use the cost of paying for the therapist services to the practice from avoiding that cost of the admission. So they just look, CBO tends to look at these things as a cost added. We've been to CMS, they say we need a law to change that. But I think MIPS gives us the opportunity to be Part B providers, and first of all, allay the fears of physicians that we will go with direct billing, because a Part B provider under MIPS cannot direct bill. You have to be a designated clinical provider. So I'm frankly looking forward and optimistic that the MIPS program will help encourage physician practices to take the risk and actually lobby for therapists under Part B, with the restriction that they do not direct bill, that the practice bill instead.
It's something I'd like to look at a little bit more, because I of course, have like this much understanding of some of this stuff, but I can, from what our billing and coding department has kind of run through with us, and we haven't really gotten pushback or anything like that. If they are referred to me, and then I have the referring physician continue to sign off as sort of a care plan, I've been billing the CPT codes and that sort of thing through the system, and I haven't really gotten any feedback that things are getting rejected or anything like that, except for when I tried to do we were looking at doing some of the newer, I think they're the complex care management education codes or something like that. They weren't big fans of trying to do that, but again, for the Incident 2 stuff, they've been pretty receptive to it. So I don't have any rejection numbers or anything like that in front of me. It's a little bit difficult to get sometimes, but they've been pretty receptive to that plan. So I'd like to hear, of course, I agree that MIPS is going to be the future, and I think that's our easiest path forward, but
well, let's talk about that offline. I know we're in a rush, but I'd like to just leave it on one final comment, just to tie into your Starbucks, Star Wars, or whatever, Star Trek, and that is that there was a saying, I think, in the right stuff, called "No bucks, no Buck Rogers," and that's exactly what we're dealing against. If we had better, a more clear reimbursement pathway for the services of an RT, we'd have more RTs employed in physician practices. Thank you.
Without a doubt.
All right. Does anybody else have a comment?
This is Chaffee. Yes, so thank you so much for that excellent presentation. There are about 10 programs in our clinic or in our network here, and about half of those are in FQHCs. The others are in critical access hospitals. There are about half of us are on the line today. This is a real group of kindred spirits. I would ask that, I don't want to take up more time for our case, but if you would send those documents to Caitlin, we'll take a look, and I know I personally would like to chat with you a little bit offline. So
absolutely.
Stop talking so we can get to the case.
All right, thank you so much, Mike. Are you okay if anybody has any questions that I forward them to you?
Absolutely.
Okay, great, thank you. All right. So,
Grace Ann, this is Dan. I can't believe that you aren't going to comment on this. Are you still there?
Who?
Grace Ann
Grace
Dorman.
Yeah, I'm here. I know Mike and I respect his work. And I think there are opportunities for both the FQHCs and the critical access hospitals, and certainly for the primary care practices to take advantage of that perhaps we're not taking advantage of. So I think this is to be reserved for a longer conversation, but I do feel there are opportunities that we are missing out on.
And I'm glad to hear your voice. You've been on my list for email for, well, since Las Vegas, actually. We weren't able to meet up there, but I have a list of ideas I'd like to discuss with you also.
Okay, well, you know how to reach me, Mike.
Yes, ma'am.
Thank you. Thank you for your presentation.
Thank you.
And this is Dan, and I met Mike at the COPD 10, COPD Foundation or COPD 10 conference in August 2017. That's the one that you missed, Grace Ann. So you missed him, but I got to meet him, and in a way that was the seed for this presentation, which is great. And as Chaffee said, it really aligns with one of our main goals and values, which is to expand the role of respiratory therapists in primary care and to use our FQHC sites to demonstrate how much they can bring to a community health center setting.
Amen.
Solo or two physician office, you're one doc, one nurse practitioner, a little harder in rural settings, but could add value, definitely. Okay, so we're gonna jump into the case. Our two presenters from Cabin Creek